All righty. Welcome. Let's see. The setting up the meeting. You guys let me know if it shows up. Oh, it says live on Facebook, so I think we're live already. Well, happy Friday. Welcome, everybody. Yes, it's working. Okay, just making sure that you guys can see what we can see. We are here with Airway Circle on our Friday Lives. So excited about the talk today. Let me pull up what I need to pull up so I know what to tell you guys. We have some very special guests. Alrighty, so today I'm so excited to introduce to you guys Dr. Gelb and Dr. Martin. They are here not only to give us an amazing class, but they are here for our party, our pre-launch for our membership. So super excited. I'm not sure if Dr. Gelb knows, but he was like our first clubhouse ever. And I also invited my dear friend, Jen Kirkman, who has been a huge part of Airway Circle and helping us getting started. So thank you so much, Jen, for being here. As you guys can tell, I'm losing my voice. So Jen's going to help me out today. So let's start. Can you guys see the right screen? I'm not sure if the right screen is on. Let's see. Maybe I need to choose what you guys can see. Spotlight for everyone. Let's see. Okay, there's Jan.
Hello. Hi, Renata. Thanks for having us.
Hey. Thank you, Jen. Do you mind going ahead and introducing yourself for those who do not know you?
Oh, not at all. Not at all. As we're preparing to get started, my name is Jen Kirkham. I am the co-founder and CEO of a company called GPS, Gelb Practice Solutions. It's the leading profitable program for airway programs in the dental practice. And it was co-founded with Dr. Michael Gelb and Dr. Layne Martin, the leading physicians of the mouth in anything airway centric and anything airway centric, excuse me. So Gelb Practice Solutions has founded a pathway for all restorative dental practices to screen and treat patients with airway issues. And so that's why they're here today talking about something as basic as the night guard. So we're going to be mentioning the TAO method, standing for TMJ, airway, and ortho, and just sharing information of things that we're really passionate about. So thank you for having us, Renata.
Of course. Thank you so much, Jen, for being here. So guys, about Dr. Gelb, Dr. Michael Gelb is a dentist in New York City with a practice devoted to airway, TMJ, and headache disorders and how they affect performance, fatigue, memory, and pain. Dr. Gelb is a clinical professor at NYU College of Dentistry and a diplomat of the American Board of Orofacial Pain. He has pioneered the concept of airway-centric dentistry and is the co-author of the book Gasp. He's also the co-founder of the AAPMD, which we love, and the Foundation for Airway Health. Okay, you guys can see me. And about Dr. Martin, Dr. Layne Martin graduated from Stony Brook School of Dental Medicine in 1998, where he received a scholarship from the U.S. Navy. After a distinguished career in the Navy, Dr. Martin entered private practice. He completed the COIS Continuum in 2013 and became a mentor at the COIS Center in 2014. Layne sold his restorative dental practice in 2018 and he completed the Tufts Mini Airway residency and became a diplomat of the ABDSM in 2020. He just finished a fellowship at the CTOR in Hoboken in New Jersey in orthodontics and craniofacial orthopedics. He has committed the rest of his career to treating sleep disorder breathing problems in children and adults. Guys, do y'all want to say a quick hello? Thank y'all for being here.
Thanks, Renata. It's great to be here. Layne, great to be here.
Yeah, thanks again. Thanks for having us.
And so I think this is a great topic to kind of introduce people, introduce dentists, hygienist, myofunctional therapist, speech language pathologist, anyone basically. Probably, what would you say, half our patients or so are wearing night guards?
Yeah, I mean, this is, I sold my restorative dental practice and I went into ortho because I realized that so many of the symptoms I was treating in my restorative practice was really the signs of a bigger problem, an airway sleep issue, including making night guards wrong for probably 15 years until I met you and realized that I was probably closing off their airway and making their breathing and sleep worse.
Right. So, this topic, we've been taught in dentistry, and it goes back to really 1924. So what are we in, 2021? So it's almost 100 years that I'd say that we in dentistry have been closing the airway. So this is about Airway Circle, and we're inviting people to come into the Airway Circle and be part of Airway Circle. And so we have to kind of own up to this fact that this thing called centric relation, how we've been taught in dental school and how the dogma that's been carried down from generation to generation has been basically to put the jaw back or not to give the lab any bite. So when you used to make your night guards, tell everyone how did you think the best way to make a night guard?
Well,
you were taught?
Well, me doing a night guard was really doing belts and suspenders after I started a case in centric relation, right? And I didn't necessarily restore them there because I found out that most people don't want to stay in CR, right? Like I feel like we were taught really the wrong thing of putting someone rearmost, uppermost, closing off their airway. So you'll see the next slide, so many patients posture forward, and we always talk about it. You see a patient with anterior wear, a lot of times those patients have an airway issue. And this, for me, I made so many mistakes looking at this case, right? This was my bread and butter. Patient came in like this. Yeah. What would I do? I'd open up their vertical, I'd deprogram them, aesthetic crown lengthening, and then I'd veneer them, and then they'd end up chipping or breaking a lot of the restoration. So this is your world.
Yeah, and I see people teaching courses on how to open up vertical. But one thing that I learned, and I started this 30 years ago looking at airway, and I didn't want to get into airway initially. I said, I just want to do TMJ. Yeah. But it became obvious in 1990 after I heard Wayne Hallstrom and John Parker. But when you look at how other people are doing it, I always tell people it's airway first. Airway trumps everything else in dentistry. Then it's the TMJ, the clenching, and then the last thing we look at is the teeth.
Yeah, and this is such a profound slide because, like I said, this was my world. And then I put someone in a night guard. And again, I made them worse, right? I closed off their airway. I put a flat plane upper splint. I probably pushed their mandible even further back. When we talk about protective function, I always talk about if in CPR, what do you do in CPR? You jaw thrust someone. So a lot of these patients that look like this is why they have wear on their anterior teeth. They're subconsciously jaw thrusting.
Let me ask you a question. Because when I went to dental school, they would show us a case like this, and they would tell us, you cannot increase vertical. They would try to tell me that these teeth would super erupt. Or if you went to some dentists, they'd probably want to do crown lengthening, Renata. They would want to send it to a periodontist. They would want to trim down all that buttress bone. They would do crown lengthening. They would try to make these teeth longer because a lot of people, now I'm going back 10, 15 years, they would never want to open the vertical on a case like this.
Yeah, the next slide, I always ask these questions, right? We always ask these questions whenever we lecture. How long should our teeth touch per day, and how much should our teeth wear down a year?
Well, that's right, and that's good, and our teeth shouldn't. So, I mean, everyone can write down what they think their answer is. I mean, I always tell my patients, one of the most important things I tell my patients is lips together, teeth apart. And I say the teeth touch every time you swallow, and you swallow 2,000 to 3,000 times a day. And so I've been around all different aspects of TMJ, and so the psychosocial part of TMJ is cognitive behavioral therapy, posture, relaxing, having the tongue up. lips together, rest oral posture, and things like that, right? So what would you say, how long should your teeth touch?
20 minutes when we swallow.
Okay.
Right? You need to breathe for 1,440 minutes a day. So you're talking about the paradigm shift. This is what I missed in my restorative dental practice. I made so many mistakes as I focused on the teeth when I should have really been focused on the airway. Not that this person doesn't need to be restored, they do. But when you want to set the case up so it doesn't fail, because I had so many failures because I never addressed airway and sleep.
Well, I think one of the primary questions here is getting at root cause, talking about functional medicine. And, you know, I could ask two questions. I could say, where should this case be restored? Now, I'm still thinking I'm talking like a dentist now. Mm-hmm. So instead of that, I was thinking about this slide today. I was having dreams about this slide. And I said to myself, when I look at this slide, I'm thinking anxiety. I'm thinking depression. In the beginning, Jeff Rouse wrote an article in the Triad. Some people would think about reflux. Some people think about panic attacks. My brain gives me to mention Alzheimer's when I see this slide. So when I talk about root cause, and you said it, you said sympathetic nervous system, you said stress. Mm-hmm. When we talk about stress, that could be a lot of things, right, to a lot of people. But I'm really looking back in the patient's medical history, and I'm trying to see what else is going on. When this patient comes into me as a hygienist, when this patient comes into me and I'm at the front desk and I'm taking the phone call, I want to know everything about their medical history, right? Do you agree?
Absolutely.
Are they on anti-anxiety meds? And what's going on? And then, as part of my discovery, I'm looking at malampati, I'm looking at tongue size, I'm looking at tori, I'm looking at myofunction, I'm looking at habit. So I think the easy way to get into this is saying, wow, it's like the American College of Prosthodontics. When you see this patient, you got to look further to see if they have an airway problem. Is that when you're? Is that how you're thinking now?
In our program, we always talk about the medical history, right? Like certain things on the medical history should be red flags. We say patients on multiple meds for hypertension. Now we're going a little bit more in detail, but those patients that have an airway or sleep issue, why are they on multiple meds for hypertension? Their heart rate and blood pressure going up and down all night. It's putting a ton of pressure on their heart. You spoke about acid reflux. It's the negative pressure, the Bernoulli effect of kind of breathing and having that. Now, the second question was a John Coyce thing for me, was 10 microns. So our teeth should wear down 10 microns a year. It would take 100 years to wear down 1 millimeter of tooth structure, yet I spent 15 years looking at this case and building up vertical and never asking the questions to the patient of, could you be more refreshed? Are you aware that you snore? Are you having all these other things? And I missed it, right? And you don't know what you don't know.
Well, and look, this is a drastic case. I think we're going to show another case in a little while. There is a part of dentistry out there that thinks that we should never change someone's bite, or that we should never do irreversible changes to the bite. And that's another subject, and it might be for another day, but I think that's a really good topic, is what's important, what's root cause, and how is this a part of overall health and wellness?
Yeah.
Right?
Yeah, absolutely.
The paradigm shift. So when I was coming up and I was going to meetings at the American Equilibration Society, my dad was the past president, the teeth were everything, right? The best guy in the class was the guy in the third and fourth year who had the best hands. And you never really married the first 2 years to the third and fourth years. The second thing you'd look at is occlusion. Then sometimes you'd look at TMJ. For some people, they look at bruxism, they put a mouth guard in like you did, and there was no such thing as airway. And then skip ahead, Howie and I started talking about airway centric in 12 years ago, let's say, before we founded the APMD. And now we talk about airway first treatment planning. Like we said, airway, when you do a restorative case or you do an orthodontic case, the first thing you should really look at is airway. That's really the tying in between medicine and dentistry, and it really is the tying in between mind and body. It's mind-body medicine. It's also functional medicine. And I think it's the best way if you want to start talking to your medical colleagues, talking about the airway. And then the second thing after airway, because that then spawns clenching, grinding. I think if you get rid of, like I agree with John Mew, if you open everything up as a kid and you expand the maxilla, we're probably going to get rid of probably about 75% of TMJ. Would you agree?
Absolutely. You know, we obviously in our ortho program, we're talking about expansion.
Yeah.
And we say it, the roof of your mouth is the floor of your nose.
Yes.
So if you expand someone, you're going to open up. You want them nasal breathing.
And the key is nasal breathing. So when we go back into this, really the key is as early as possible in life is to get them to be a nasal breather.
Yeah.
And that's a whole other question. So that's the new paradigm. So when this patient would come in on the left, and you would your mouth would water probably, right?
Yeah.
As a restorative, you studied with Larry Rosenthal, right?
I did. And so looking at this case, now we look at it from an orthodontic standpoint, you look at it from an airway standpoint, it's narrow buccal corners. However, what I used to do was the patient would come in and I'd build out their buccal corners with porcelain.
Right.
I treated her symptom and I never treated her root cause
Right.
problem.
You treated those black lines, those buccal corridors, you call it?
Yeah.
Those black, that when you take the photograph, it just appears black and you go, God, this is a cosmetic problem. Now, beautiful woman, but now that we look at it differently, she's tired.
Yeah.
Now, in taking her history, she's either taking Unisom, NyQuil, Benadryl, she circulates. This is like 50, 60, 70% of my practice. Perimenopausal woman never really gets a good night's sleep. Like that's the bane of her existence. And probably Renata, that's the number one complaint. I don't get refreshing sleep. That's the number one thing that people say to me when they come in. I want to get refreshing sleep. So when we go deeper into the medical history, that's the stuff that comes up to me is how can I get this woman's brain down into deeper sleep? So today, when you look at those books, now we're thinking narrow nose, narrow palate, narrow nose.
I'm thinking ortho. When I look at this now, I think ortho, and that's what we want the hygienist, the dentist, the front desk person to look at this. And yeah, she's going to want to get her teeth restored because they're chipped.
Yeah.
But airway needs to be the driving force on every treatment plan.
And I love Bill Hang's line. You know, what we did on this case is like putting makeup on a melanoma. So I always give you the question. You go in Brazil, Renata, we go into, and this is not Brazil, this is the United States. You go in for some filler right here, right next to the filler, there's a melanoma. The dermatologist doesn't mention the melanoma. They just put the filler in. They don't even mention the fact that there's a melanoma. I think that's malpractice. You go into an Invisalign dentist to straighten 2 teeth. There's no airway there. They don't mention the narrow airway, but they give you Invisalign. So we're talking about a shift in thinking. We start off talking about bruxism. By the way, she's cracking all her teeth.
Yeah.
Now, she had severe wear of those teeth right there. And when you look at we turn it to chipped teeth, broken restorations, you used to see that all the time.
Yeah, you know, Gerald Simmons is a neurologist. He wrote a great paper and he lectures about sleep bruxism, airway issues.
He's great.
Like what's causing that to happen, right? That's what we have to start looking at is what's the cause of a woman looking like this, or how is she compensating, or why is she breaking teeth, or why does she have wear or collapse vertical?
And he's a big advocate of upper airway resistance syndrome. So this is our friend. So this is my case going back. I just saw her again. I think this goes back to 2014 maybe. She's tired, she's in pain, she's irritable, and she's depressed. So that's kind of my whole practice. She's a 4 bicuspid extraction, or she's an upper 2 bicuspid extraction case. So this is like my father went through this for 40, 45 years before I did. I've only been in practice 38 years, so I'm learning. But this is really our classic case, would you say?
Yeah, this is my favorite case. I looked at this case and I lectured to the residents in my ortho program. We spent an hour just looking at this composite, right? Because there's so many things going on. You know, as dentists, we used to look at just this.
So so let's
right? Look.
What do you look at? So tell me what do you look at first?
Right here, I look at her face. Right, she looks tired. She has the venous pooling under her eyes, right, from the nasal congestion.
Look at those
My favorite
labial folds.
Yeah, the second picture, obviously very narrow buccal corridors. She has crowding. Third picture, I love the profile picture. We look at chin throat length. You could see the retrusive mandible.
Right. So just to say it again. So Renata, she's got no chin.
Yeah.
Her chin goes right into her neck immediately. Now, what I look at all the time now, I look at the dowager's hump. Yeah. I look, so what we've learned from Rockabato, what we've learned from Greg Johnson, what we've learned is the forward head posture is a compensation to open the airway. And I would say probably 60 to 70% of my perimenopausal women, and by the way, I'm starting to see it in young girls now that are on the iPad. First of all, every girl, as she's developing, she's like this. She's got the rounded shoulders forward. Now, that just gets worse as the airway gets smaller. We're going to see the cone beam in a second. But I'm a big advocate in working with the physical therapist because almost all these people are going to have compression around C1, occiput C1, C1, C2, even going further. And especially, you'll see that C5, C6. What else do you see? The maxilla is too far back?
Yeah,
obviously.
Well, she's got retrusive upper lower jaw. They took out two bicuspid. She's got a transverse problem.
So let's
very narrow.
Let's stop right there. She went to a freaking orthodontist, and what were they doing? What were they thinking? Pulling her maxilla back. So that's what gets me so upset because it's still going on in this country, okay, in the United States on a daily basis. So they pulled her maxilla back to match her retrognathic mandible. That's criminal to me, right? I mean, to me, it's criminal.
Yeah, and Bill Hang, who's one of my mentors and a good friend of Michael and ours, he talks about the extraction, retraction, regret syndrome. Right. So Bill used to do this, right? He used to take out 4 bicuspids and realize that he was hurting so many of these patients. And he dedicated the rest of his career to really kind of advocating for not doing this. And this is a woman who, she's been like this since a child. And now she's having all these problems as an adult. And if you told her to put her posture better over her shoulders, she'd suffocate. Yeah, right? She's posturing forward to open up her airway like we spoke about before.
Exactly.
CPR.
So by the way, you go to a physical therapist, you're having headaches, you're having neck pain. Physical therapist, you cannot, like you said, you cannot change her posture because she won't make it through another hour, another 5 minutes. So you go to the physical therapist, they do an adjustment, patient comes out, they got to take a breath. They just spun back into their forward head posture. So this is a really important thing. If anyone's working with physical therapists out there, if any of you are treating people that have chronic neck pain, you've got to stabilize the jaw in order to stabilize the neck. So
wait, hold on. I want to just say a couple of things. This patient 5 years ago walks into my practice. I don't even look at her face. I look at the dentistry, right? I look at the crown and bridge. I look at the large amalgams. And I probably restore her like this.
You probably do. You take out the amalgams, you put in a zirconia, you put in pressed porcelain.
So from an ortho standpoint now, and I want every hygienist and dentist to look at this, is if you look at the bottom photo, right, we talk about X-bite, and I don't know if everyone remembers Kerber Wilson from dental school, but if you look at her lower molar inclination, she's really kind of dumped in. And she has no room for her tongue. And obviously that's because she has a restrictive maxilla and mandible. And so this woman needs ortho. She needs really the extraction spaces reopened.
Absolutely.
Right? And have that transverse and also the sagittal fixed. And the other thing we look at is she obviously has a trapped mandible. Her lower jaw, she's got a severe overbite.
Yes.
Right? You always talk about that.
Well, now you know what I started to do? Since Jeremy's coming in, I measure the molar to molar width. And the molar to molar width here is probably about 27, 28. And Bill Hang says 40.
Yeah, 38 to 40 millimeters.
So she's about 12 millimeters deficient in her width of her maxilla. So, but in the old days, you would have done the dentistry.
Absolutely.
You might even put laminates on this case.
Probably.
Right?
Yeah.
And that's probably what most of the courses in the United States are going to teach. This is a great case, but that would be the wrong thing to do in this case.
Yeah, so this is her cone beam.
Right, so you know what I always say, a picture is worth 1,000 words. So you know what, you might miss it. You may not be advanced, but if you have someone in your office that's really good at looking at pictures, by the way, when the patient sees, and Bill Hang had the greatest line, airways come two ways. There's the coffee stir, there's the straw, and there's the garden hose. This is like a half a straw or 2 coffee stirs. This is a very narrowed airway. I always say less than 120 millimeters squared. This is probably about 50 or 60 millimeters squared. We might see it on the next slide, but I look at it in 3 different dimensions, and I wouldn't take on the coronal view, which is the bottom left. I'm really looking at the nose, so I would do a different cut here probably. I go a little bit further forward, but we just see that it's a very narrowed airway, and obviously as you push the jaw back, the mandible and the maxilla. See, the reason that we're here today, Renata, is that the dental team, we're working with the maxilla and the mandible every second of every day. We are the masters of expanding the maxilla. We're dentists, we're orthodontists, we're general dentists. So there's no one better than us to open the airway, open the nose while you're expanding, move the maxilla forward, move the mandible. And if you do that, you're going to open the airway. So it's one way of, now we're talking eventually about growing the airway. That's why you're going back to school.
No, it is. Listen, this CV cone beam is amazing adjunct. But really what our message is that the patient that comes in, either to the hygienist, to the dentist, with the wear, the high vaulted palate, the large tori, the large tonsils, right, the narrow buccal corridors, they have a bigger problem. Now, we use this tool all the time, and it's a great tool to explain it to the patient. But when you see that patient sitting in your chair with the wear on the anterior teeth, you know they have a bigger problem.
And listen, but I believe that everyone still, you and I I don't know that we disagree, but I think the standard of care now is a cone beam.
No, it is. I'm just saying for the offices that might not have that technology yet, and I think it'll be there. It'll be like digital radiography. It'll be like intraoral scanners. Every office will have a cone beam. However, if you don't, looking at the signs and symptoms, looking at the medical history, the airway exam, you'll be able to tell the story as well.
Right. So I get rid of the headaches, the neck pain, the clicking, the popping. I use a modified Gelb appliance during the day on the lower to move the jaw forward. We're going to see it in a second. And then we use, this is a prosomnus appliance, we use an oral device at night that's adjustable to keep the airway open. And you're going to see, so we're going to talk about a couple of different devices. Why don't you tell us about the new night guard?
So interestingly enough, the way that you and I got together was a year ago, I realized in my ortho program that most of the adult patients that were skeletal class 2, so their mandibles were really trapped back, were having significant TMD symptoms. I reached out to you. You were like, Layne, come on in.
Right.
And I realized what you do with your Gelb appliance, where you reposition the mandible forward, is what we were doing with bite block therapy in ortho. So we were taking those patients kind of down and forward, and then, you know, addressing them at that point, which we were talking about. Every restorative dentist and every orthodontist could utilize this appliance.
Right.
Right, to bring their mandible. And really, the mandible dictates your airway dynamics. Right? If your mandible's back, everything's going to close up. That's why we were talking about centric relation.
The tongue is attached, anatomically, the tongue is attached to the mandible at the genial tubercle inside.
Yeah.
So if you bring the jaw down and forward, now, long face syndrome, we don't want to make it, but in general, if you bring the jaw forward, you're generally going to open the airway. And so you came up and we came up together. We started using this with Great Lakes. It's an upper appliance combined with a lower appliance, and it has a little anti-retrusion ramp on it to give the mandible the idea and the support to stay forward at night.
Yeah, and we've modified it a little bit now, almost making it similar to class 2 and class 3 elastics.
Right. So the elastics will help keep the jaw forward.
It will. So you could wear this
Right.
appliance, it's a lower Gelb that you wear during the day.
Yeah.
And then at night, you just have the anchorage against your maxilla.
So in other words, it's almost in a phonetic position, Layne, 66. So for those of you out there, everyone, how do I take the bite? How do I do it? Well, most of the time, if you have your patients say the sibilants, 66, 66, 67, Mississippi, you're going to notice that the jaws will usually come back to the midline. Often it will, but the jaw usually will come forward into a speaking.
Yeah, and a lot of people have a functional shift. So taking that phonetic bite, so probably a lot of people watching do sleep appliances, they use a George gauge. You hear it talking about 50 to 75% of maxillary protrusion. The premise for us is we just don't want your mandible to fall back.
Right. So the way you describe it, so I say to my patients, because some of them get scared, the dentists get the most afraid. So I say, I'm not going to bring, it's not that I'm bringing your jaw so far forward, I'm preventing your jaw
From falling back.
from falling back at night. And then I give them my old, and then I bring my jaw forward, and there's no sound. And keeps a lot of people happy. So, we basically are talking about, we didn't give you the before and afters, but I will tell you that going back to Lisa's case, so when we put in the appliance, and now she's back to us to do the orthodontics, and I'm so happy to be treating her and be able to open up those spaces with Jeremy and with you. She went from 69 events per hour down to 8. She went from 365 DSATs between 4 and 9%, and I think 101 between 10 and 20%, down to 12 and 0. So it's not that it's one of my most successful cases, but it is in terms of before and after.
Yep.
It's the notes I get at the holidays. It's the hug I get. It's the thanks that I get for basically, she's now divorced, okay? And her kid's doing great, and she's doing great. It's basically transforming her life only because we as dentists recognize that we could have a role in the transformation process.
Yeah, and we spoke about the night guard. On Lisa's case, absolutely, I would have made her an upper flat plane splint. Yeah. Right, if I veneered her case.
Oh, in the past.
And what would I have done? I would have veneered her case. I would have tried to make her a little bit wider from a buccal corridor standpoint. And then, like I said, the belts and suspenders, I'd make her an upper flat plane splint. So now I would take her, she already has a narrow, high vaulted palate with a restricted maxilla, and I'd make it worse.
Right.
Right. And also, I'd probably drive her mandible even further back. So I probably would make her airway and sleep worse. I just didn't know better. Now I know better, which is why we're trying to share that information with everyone watching.
So I'll say that one more time. 90% of the time, her included, she's going to come in, seeing her general dentist who put in a flat plane appliance, beautifully made, cuspid guidance, posterior disclusion, anterior guidance, but made in a retruded position. So killing her, but on the autopsy, they don't know you did it. So you kill her a little bit every day, so no one pins it on the dentist, but you're not helping her. We're supposed to do no harm.
Yeah.
This is the case where if you put in a night guard and you only increase vertical, you're going to close the airway. Yeah. So what the American College of Prosthodontic position paper said, if you're going to make a night guard, you've got to have some degree of protrusion, advancement in the night guard, correct?
Absolutely. And there are going to be bite changes, right? There's definitely going to be bite changes.
We want bite changes.
You do, especially in a case like this. The conversation to have with the patient is, listen, you know what, Mrs. Jones? Your teeth are going to come forward.
Right.
You might be contacting
them. Your jaw will come forward.
Your jaw will come forward. And you might need some type of orthodontics or restorative after to just kind of give you that posterior support. So it is a conversation to have. But this is a way healthier position for her to be in down and forward.
Well, and I'll tell you, she's been wearing this appliance for 6 years. She's been wearing an upper appliance, and we've been holding her like so I think the thing that's changed in the last 5 years, if I treat someone who's 35 or 40 or 45, we're no longer happy. And you're part of the change in my thinking. I'm no longer accepting keeping them in a device for 40 years. That's been the shift. The shift now is that we've got to start growing the airway. Yes. Should we do it at 3 or 4? Yes. Was she made worse at 10 or 11 or 8 or 9 when they took out those bicuspids and pushed? Yes. The dentists, our dental community made her worse. But we're no longer, I think, accepting. I think we're looking to grow the airway. We're trying to make it so she doesn't have to wear a bite plate all day and all night.
Yeah, and I worked at an ENT office. You brought it up. I had a 25-year-old patient,
right,
had sleep apnea, had a night guard, had a prosomnus appliance, and asked me, Layne, do I have to wear this for the rest of my life? Right? How do you give someone an adjunct like that and tell them, listen, wear this appliance for 60 years? Absolutely not. That's why the orthodontics, especially as restorative dentists, as orthodontists, we have such an amazing opportunity to really grow the airway and fix the problem and not just the symptom anymore.
Right. So what I want to say is that going back, when someone walks in like this gives us as a dental community, as an Airway Circle, this opens up our world so wide. I can now address things. When I address the airway, I can address anxiety. I can address Alzheimer's. I can address panic attacks. I can address failure to thrive and growth issues. I never imagined that I was going to be working leptin, ghrelin. I can do weight loss. I mean, I can do whatever I want to do because my world. And so what it does, it expands your treatment plan. Forget about just the laminates and the guard. You're talking about whatever the patient needs. And it's all about health and wellness. It has nothing to do with the teeth.
Yeah.
It's not, dentistry is not about teeth. And if I could get that point across, dentistry is about so much more than teeth. It's great that we can do great dental restorations, but you're going to do more dental restorations than you ever imagined, but you're also going to do this other stuff first in preparation.
It's setting the case up.
Right.
Right. And that's what I would always tell students that I taught about how to do veneers and crowns. It's anyone can do a veneer, right? It's setting the case up so it doesn't fail. Now, I had failures because I missed this, right? I looked at it and I would open the vertical and I'd mount the case and I would deprogram the patient and I'd put them in provisionals and then I'd probably deprogram them again, but I really missed their real problem. So when you see a patient that walks in like this with anterior wear, you know they have a way bigger problem. And that's when you have to make the inquiry about their airway, their sleep.
So Jen, Renata, let's open it up to some questions. If we can get Renata to come back, what do you got? Renata, what do you got for us? Anyone out there have any questions, comments?
Jen, I'll let you go first.
Yeah, I can jump in here. It looks like one of the questions that we see refers to the case with the retrognathic jaw. That's something that our audience here sees all the time. So it's no coincidence here that I think our audience is seeing this and it's the majority of your practice. So what's the first step that you would take in the treatment plan, looking at airway first? If they see this so often, what is the first step that they should take? Well,
I'll tell you what I do, and then you tell me what.
Sure.
See, Layne's the restorative guy. I'm like airway and TMJ. So because you see the mandible is the one that moves. The mandible is the moving part. The maxilla. So I immediately bring the jaw forward. You see how she doesn't have a defined, she has a jaw there. Her jaw is pressed, has been protruded so far that her jaw is now melding into her neck. I'm going to give her, and by the way, I always say this, I am the best cosmetic dentist in the world. And I'm not going to show you, Renata, you know I'm humble, right? But I'm not even, I haven't shown you any of my before and afters. I don't need to, but I can show you no teeth. And yet what I do for eyes. And so the first thing I'm going to do, because I could be an aesthetic dentist, the first thing I'm going to do is I'm going to move the jaw forward into almost an edge-to-edge position, a phonetic position. That's the first thing. That's during the day. I'm going to order a sleep study, and I'm going to see, is this snoring? Is this upper airway resistance? Is this sleep apnea? And then I'll probably end up using a FDA-approved, some sleep device at night. Now, here's what you taught me. I tell you this all the time. we can't use anything bulky. She has no palatal width.
Yeah.
If I put something in her mouth that has any lingual coverage on it, I'm going to make her worse. So I have to pick an airway device that's not going to take up that value of real estate. It's like Fifth Avenue, Monte Napoleone, pick the avenue of Brazil that you want, Renata. That real estate on the top, Worth Avenue, that real estate on the top is so valuable. So, you know, some of my colleagues would go in and they would start doing the orthodontics immediately. I'm a little bit more conservative. So what would you do first in this case?
No, I think you address her acute problems, right? She's tired, she has pain, and that's the other point here. No one walks in like this and says, hey, doc, you know what? I have an airway issue. They're coming in with TMJ pain, masseter pain, wear, broken restorations. It's just that when you see this now, you're going to think, all right, this person has an airway and sleep issue. So to your point, you address her acute issues.
That's great.
You reposition her mandible.
Yes.
And then you could do the restorative and really ortho. This patient absolutely needs ortho. You can get her lower mandible forward. What's going to happen though is when you bring her mandible to that phonetic position, her posterior teeth are not going to touch. She's going to be edge to edge. So that's when you do the ortho. You do the transverse expansion. You do the sagittal.
Let me go back. You said one really, really important thing to me that I heard. You said the patient's going to come in, and this is Airway Circle. The patient never comes in unless they've read the book Breath or the book Gasp. I have an airway. They know. They never say, I have an airway problem, doc. They go, no, I'm fine. But you know what? I'm tired. I'm in pain. I'm breaking teeth. They come in with real, thank you, those two books. I come in with real problems. I don't know I have an airway problem. That's for you to figure out. So you're right. I have to get rid of the acute problems first, and then I educate them. I show them what a narrow airway is. I show them my model that I use all the time that shows when the jaw is back, the airway is narrowed, and as the jaw comes forward, the airway opens up. So I hope we answer your question. We take care of the acute things first. I don't jump in like some of their techniques out there where they jump in right away and they want to sell a $10,000, $20,000 case. We personally don't do that. We go step by step. We develop a relationship with the patient, and then we'll get into ortho. It might take us 2 months, 3 months, could take us 6 years, like in this case.
Yeah, and the other benefit of doing either a lower Gelb or the appliance that we're inventing, or even a traditional sleeve appliance, you're going to bring their mandible down and forward. You're going to really help remodel their condyle, and then the ortho becomes a little bit easier because you're really addressing the sagittal part. She definitely needs the transverse part. We already said that, the high vaulted palate. She's having a lot of the sinus issues as well.
Okay, next question, Jen. For Renata.
Yeah, I have a question here. For the audience of Airway Circle, a lot of these are hygienists that also work in myofunctional therapy. What do you see as their role as it relates to the night guard, specifically with this topic? What can they do with the patients? Like, do you see them, how can they assess the current night guard? You know, what do you recommend in starting the conversation there?
Sure. You want to go first?
Yeah.
Okay. So, you know, I was talking to Howie yesterday. First of all, the hygienist is the one that's looking at they meet this patient. The minute that they look at the upper two bicuspid, the narrow upper arch, the high vaulted palate, if you try to do myofunctional in this case, and you're trying to get the tongue up into that very narrow space, there might be a lot of, and there could be tongue restriction. Okay, I got that. But you've got to make, in a lot of these cases, you have to provide the real estate so the tongue is very happy and has enough room. How wide does the palate need to be?
38 to 41.
No, but it has to be wide enough to handle the tongue.
So the point is, I have expansion right now.
Okay.
I need myofunctional therapy.
Right.
I can't do it yet because my palate looks like this.
Yes.
So I need to have the expansion first. You hit it on the head. Then I can get my tongue up there. Obviously, I could still do the exercises and I can go laterally.
You know what?
Absolutely.
You're right.
you know, we talk about the hygienist. Jen and I and Michael spoke about renaming the hygienist to the oral PA.
Yes.
I love that. They're really the frontline defense in so many offices, especially now with DSOs coming to fruition. A lot of the patients are seeing the hygienist first. And looking at a patient like this, we want you to be aware of, you know what, I think this person has a problem. I want the front desk person to even look at the woman's profile and say, you know what, doc, I think this patient's going to have an airway or sleep issue.
Right, and so you can find the film. But I would say if you have Renata, if you have a Jen Kirkham, if you have a Marissa Gelb, they could actually be my triage. They could be triaging. All you need is a dentist that they can whip into shape, okay? All they need is a dentist that they tell them which courses to take. But if I have a smart hygienist in the office, she could be running, she could be sequencing, and you said it very well. How do you sequence the case? So a lot of success in relationships, a lot of success in business is how we sequence something and how we explain it. So we call it sequential treatment planning. You know, we're going to do this first. Let's try that, because you can overwhelm a patient. If you try to put them into everything at once, you're going to overwhelm them. They're not going to do anything with you. So that's why I'm glad that you agree. We start with getting rid of the pain. If I say to someone, I'm going to get you out of pain and I'm going to make you more refreshed. And you know what? I was lucky that I had a father before me that moved the jaw down and forward, because thank God, serendipitously, when I moved the jaw down and forward, I'm opening the airway. So even with every appliance I make is an airway-centric type of appliance. I've taken a commitment and a vow with Howie Hinden. I'm not going to do anything that's going to close your airway. And I think they have to hear that. They have to understand that we're airway first type of people. So we're very pro hygienists. We're very pro speech language pathologists. We want you guys to pick it up first if you can.
Very, very good. That is a common question that we ask. When should a patient start myofunctional therapy? Whenever they're doing extension, because you can't get your tongue up there whenever you have a device up there. But in certain cases, there are a few things that we can do before. So we can work on nasal breathing. We can work on other muscles, posture, things like that. That might be helpful before. So work in conjunction sometimes does go well. I have a question over here that's a 3-part question. And I think you guys already answered some of it, but I'll just read the whole thing. It's from Lael. She says, how long are they in this position with the appliance? Or is this until they can get expansion or jaw surgery? Do we have to screen and evaluate the jaw joints to confirm they are stable before appliances like these?
Great question. So I would say I like to keep the patient, have them be at least 2 months pain-free. I like to keep them at least 2 months pain-free. But if I'm trying to find the final position, we used to say 3 to 6 months with an airway device, because the bite's going to change. So yes, the jaw has to be stable. I want to get rid of clicking and popping. I want to get rid of locking. I want them to be able to have no pain in their masseter temporalis, trapezius, sternocleidomastoid, posterior. So I have to work. We didn't mention the physical therapist. I work with Brad Gilden, Greg Johnson, Ron Harushka. You and I both work with airway-centric physical therapists. They're doing pressure. They're making sure the diaphragm works. They're working on pressure gradients. And so when I work with a sophisticated physical therapist, they're as much of the team as the hygienist and the speech language pathologist. So I'd say it takes at least 2 months. It takes 6 to 8 weeks for sarcomeres to lengthen, to get different rest posture, to break habits, at least 6 to 8 weeks. And then, listen, I've been holding her steady. I've been keeping a lifeline to her so she could raise her son, so she could get divorced, so she could get a new house, a new apartment, so she could survive and thrive and lead her life. Now I'm going to do the orthodontics with her, but I will go. It's not how it's a marathon. Life is a marathon. Life is not a sprint. So we just have to manage it with costs, with family, sending kids through college. You know, I have a 2-year-old in front. What would you say with sequence?
No, I mean, Renata brought up a great point. This is a multifactorial problem, right? So you addressed it. Myofunctional, she has a soft tissue problem, right? She might even be a little bit tongue-tied. She also has an anatomical problem. And I think in dentistry, we've always looked at things as very black and white, right? This is their anatomy and we have to fix it. But there's also soft tissue. I mean, you brought up a point about the coffee straw and the McDonald's straw, which you hear a lot on the airway circuit. But if I told you the McDonald's straw is paper and the coffee straw is plastic,
right,
the McDonald's straw is going to be a lot more collapsible. So it's not just looking at anatomy, there's soft tissue. We're huge believers in myofunctional therapy. So all the patients that need ortho, for the most part, should have myofunctional therapy. Absolutely. I mean, that's a bold statement, but I'm seeing orthodontic surgical cases relapse because no one addressed the tongue of the soft tissue. And let me tell you, I was in the Navy doing orthodontic surgery. That is a barbaric procedure to have relapse.
Yep, and so you know what? I love it when they've come to me and they've had myofunctional. I love it. I'm now getting referrals from, you know, a good amount of myofunctional therapists, speech language pathologists, hygienists, and I think it's wonderful. And so it's probably going to need that. So when all the studies showed, whether it's ortho, adenoids, tonsillectomy, palatal expansion, every case does better when they've had myofunctional in terms of preventing relapse and in terms of, and Camacho studies, all his meta-analysis. We're going to do better if we have myofunctional therapy in every case.
And Renata, the other thing that Michael, myself, and Jen always talk about is the speech and language pathologist. Now, I've lectured to that group because so many of those kids are really behind the curve in terms of growth.
Yeah.
Right? And they're just not getting oxygen to their brain. I mean, that's a whole other topic we could speak about for hours in terms of the ADD, the ADHD, you know, the failure to thrive. So many of those kids need early intervention. In my ortho program, I mean, we're putting bondable expanders on 3, 4, and 5-year-olds. And when they're saying, no, the orthodontist said to wait till 10 or 11, they're missing it. Because at 3, 4, 5, the kids' tonsils and adenoids are the largest. Our mandibles and maxilla are the smallest. And that's the brain development, right? By the age of 5, 98% you have brain development. You have to intervene early.
Go ahead, Renata. Another question.
Sorry.
That was a good
I love the way that you brought that up. I hadn't seen anybody talk about a paper straw and a plastic straw. That's genius. I love that.
Collapsibility, yeah, it's great. That is genius because I'm doing a lot more paper straws now that everything is recyclable and they break down after about 10 minutes.
Very frustrating, but good for the environment anyways. Somebody has been asking about, let me think of Susie. What are your thoughts on Koi's deprogrammer?
You know, I'll talk. Layne, you know, Layne studied with Koi, so it might be politically. So if someone comes in with a deprogrammer, you know, it's generally people that have been taught by prosthodontists or Kois, or, you know, these deprogrammers are nice, but, you know,
what is a Koi deprogrammer?
If you put like a Lucia jig, you put something like an NTI, it only hits in the front. It only hits in the front 2 teeth. It's meant to relax the muscles. But this is the whole issue with neuromuscular too. You want to know, what are you trying to achieve? So just because I'm going to deprogram the muscles, are you trying to find a better position for centric relation? Are you trying to find like where you're going to restore the case? Most people that use Kois deprogrammers, and I'm going to generalize, most people that use Lucia, forget it. If you use a Lucia jig, it means you're an old guy like me, older than me, and you're probably trying to find a centric relation position, and you don't even know that there's a term called airway. So it's good if you're in the airway circle, you've at least heard of something called airway, and you're aware of airway. So I never use the term a deprogrammer or a jig in the same sentence when I talk about airway. How would you say it?
I mean, that was my world, right? I was a restorative dentist, and I went out to Kois, and it changed the way I did dentistry.
And I thought you were great after that. You realized how much
I thought I was great before that, and then I sat there the first day realizing how much I didn't know in dentistry. And I went through the program, and I learned so much from John. Amazing mentor, and I would deprogram cases. Now, the other thing about a Kois deprogrammer, which is interesting, I learned this from someone, and I kind of put a spin on it. Putting a deprogrammer in or putting someone in CR is like putting training wheels on a bicycle. right? You start out that way, and now being an airway dentist and an orthodontist, I look at it differently. Yeah, you start out that way, but you don't restore them that way. You don't restore them that way because they don't want to stay there, right? We just saw a case the other day, myself, Michael, and Jen, and I, where it was a class 3 patient, and they put veneers on the patient. And I've done this. I've made this mistake. I veneered the patient, I restored their class 3, and I ended up trapping their mandible back. Now, what happens? That patient's going to want to posture forward. They're going to want to posture forward to open up their airway. And that's what happens, I think, when we talk about Lucia jigs, deprogrammers. Patients are going to want their mandible down and forward, right? They're going to want an open airway. Their brain's going to be like, listen, you have to breathe. So it's a matter of how do we put them there, restore them there, and keep them there?
Yeah, and a jig may be good for the day, but Renata, it doesn't really always serve the purpose at night when gravity can take everything back. So I hope we answered that question.
Yes, last question. Somebody just said 64-year-old Caucasian female, still treatable.
What's the question with the 64-year-old Caucasian female?
Is she still treatable?
Of course. Of course. We treat people into their 80s and 90s. We want to make a 64-year-old feel like a 40-year-old. So she's after menopause. That's when she's going to get sleep apnea. Oh, my God. You just have to look at Juvabite. But, Jen, we should put some on our website. We'll put some morphs on our website so you can see it's an anti-aging effect. If you're into anti-aging, if you're into functional medicine, our patients look 10, 15 years younger after about 2 to 3 months of our treatment. So it's a tremendous, I say it's an old Brazilian Portuguese recipe with a little Jewish put in. It's a little bit of oxygen and a little bit of restorative sleep. We taste it, add a little bit more oxygen. And then women and men, but women have a tremendous ability to heal themselves if you just give them the right nutrients and air and restorative sleep.
Yeah. I mean, I'm 48 years old, so I went back to school at 45, and I have a traditional expander in my mouth now, and I would say within 2 months, I started breathing better through my nose, right? Because we were taught in dental and hygiene school that your sutures are fused. They're actually not. It's really more the functional matrix theory. So granted, my expansion is going to take a lot longer than someone that's 30, but we're seeing expansion. We do it all the time in our program. Michael does it here. Jeremy does it here, whether it's, you're using clear aligner therapy, functional appliances, traditional braces. We just want the patient to get expanded.
Yeah, listen, we use Vivos, MSC, controlled arch, facial beauty, Invisalign, clear aligners, regular expander. We, whatever technique you like, that's the end stage of how we grow the airway. But whatever is most appropriate for whatever age group is what we use.
My goodness, guys, we seriously could be here for another 3 hours, I think. I love listening to everything you guys have to say. I'm getting messages over here like crazy. Is this going to be recorded? Is this going to be recorded? I need somebody to watch this. I need my dentist. I need my dad, my father.
Yeah, and listen, if you need more information, you want a copy of our slides, you want to find out more, you can contact us or Jen at support@gpsfordental.com. I'm happy to try to put you in touch with my book. And if you need any slides that you can teach other people, we're happy to provide you with slides. That's my book, Gasp.
Yes. How about if let's give one away? I have one to give away.
Let's give it away. And by the way, all those hospitals, the libraries that you're talking about, so if you can give me a list of the libraries that need that book, I'm happy to provide them at no cost.
Oh my gosh.
If you keep it, I can do up to like 100 different libraries. So I'm happy to donate that for Airway Circle. If you can identify 100 different libraries, I'm happy to send them at no charge the book. So let's give it away. Who do you want to give it away to?
Amazing. Jen, do you have any idea? Let's pick everybody who's watching over here and Facebook.
How long should your teeth touch?
How long should your teeth touch? How many?
I love that. Who gets the closest? Yes. In minutes?
How many minutes a day should your teeth touch? If you could, whoever gets the right answer, get a free book.
Okay, we got 1,400 minutes. Let's see. Go ahead and answer, guys. We'll get the closest person. Will get a copy of Gas, which is a fantastic book if you have not read yet. 20 minutes, 20 minutes.
20 minutes.
It's 20 minutes?
Is that
Yeah.
Right?
20.
Anyone get it right?
The first person who answered 20. Oh my goodness, there was a couple people.
It was Bernalia on Zoom.
Anyway, we'll give away as many books, as many people answered it, they all get a free book. Just
Oh my goodness, that is fantastic.
20 minutes. And it's
20
been a
minutes
pleasure.
is
Renata, you're doing great work, and thank you so much for what you're doing.
Yeah.
And we really appreciate it. Jen, thank you very much for helping us and moderating us today as well.
Thank you guys so much. I do have, if you guys have to go, please feel free. I have a question for Jen before we leave.
No,
We're good. We're good. We're here.
Yeah, we're here.
All right, Jen, what events do you guys have coming up? Can you tell us a little bit more about the next event you guys have in the works?
Yeah, definitely. Something that we're really, really excited about. Renata, as you mentioned, we could spend 3 more hours here talking about all of the things and sequential treatment planning and really knowing where to start based on where the patient's coming from and how to support you as providers. So if you can let me share my screen real quick, just wanted to show quick visuals of where we're going to be in October. So in October, we have chosen to participate with the Dental Festival. And so we're going to be in Hollywood, Florida on October 15th and 16th. And so here's a quick visual. So October 15th and 16th, if you can save the date. And this is really the framework to continue the conversation and lean in on support from various professionals, not to mention hearing more from Dr. Gelb, Dr. Martin, but we're going to hear from our other faculty members that are trained in virtually every program that we hear of these days, right? Myofunctional therapy, speech language pathology, Vigos, Agafaga, like all of it's going to be discussed and addressed. So you're going to get clinical know-how to how to work with cases and the workflow and implementation strategies and essentially everything that you need to start doing cases on Monday. So in order to get there, we want to give as much as we possibly can, but do email us at support@GPS for Dental. Ask for those slides, ask for any additional resources. How can we help you? And in a thank you for having us as guests here, Renata, we want to offer a $200 off coupon to the Dental Festival. And when I send you the slides, it'll be a clickable link. And we welcome all of you to register for the event. Do click quickly because there is limited seating. This is a private invitation-only event. And we wanted to offer this coupon first. Airway Circle is first to get access to this $200 coupon. So let's blow it up with Airway Circle members, shall we?
Yay, that is fantastic. Thank you guys so much. And just to let everybody know, we are live. We just did a pre-launch right now of our membership. So to explain a little bit about what our membership is going to include, we have a file of research studies that you're going to be able to access and download. We have several products and companies who are working directly with us. Airway Circle is not making any money whatsoever. I have been offered affiliate codes. I said no to all of them. I just want a bigger discount for our members. So these are discounts that you're not going to be able to get anywhere else with these products if you are a member of Airway Circle. You're also going to get, we have courses coming up every month. It's going to be either the first Friday or first Saturday of every month. We're going to have a specific course. So the first year we have 12 courses with incredible speakers. I cannot wait for you guys to see our lineup. And those are going to be available at a discounted rate for Airway Circle members. Those are going to have CEs. So AGD members only CEs. We're working on ASHA, which is super hard. Help out, ASHA. Also, as a member, you're going to support us in our continued vision of bringing these courses to you guys, bringing these free classes to you guys. Right now, we're doing 4 or 5 free 1-hour meetings a week. With guys have seen incredible speakers. We do giveaways. We also have an amazing free directory. We have 136 professionals right now. And the directory has been super helpful, not only for patients who are looking for providers to help them, but also for providers to see meet other providers that they can collaborate with. So there were people around me that I didn't even know. There's an orthodontist close to me who works with Dr. Gelb, actually, who I had no idea, and now I can send him patients. But because of Airway Circle, all of these amazing collaborations happening with so many different people. So we're super thankful. Airway Circle is not me. It is not, I can't do anything by myself. So I really need everyone's help to share our posts and tell other providers about it. If you work for a dentist, please invite them to come over. If you'd like to be featured, send us an email, and we'd love to have you over here too. We're all about, connect, share, and collaborate. So thank you all for being a part of this amazing dream of ours. And it is blowing up, and it is so exciting how many more people we're able to help by sharing all of this information. So let's keep doing it. Thank you guys for being here.
Thanks again.
Thanks, Renata.
Thank you.
All right, everybody have a wonderful weekend, and we'll see y'all this week on Tuesday, Thursday, and Friday meetings. All right, we have Dr.
Friday.
Mary Burke on Friday, by the way, my Omanchi. Super excited about that. Bye, guys. Thank you.
Bye-bye. Bye-bye now.